You know, if you're in the community, this is a drug that takes the whole day to infuse. Is it worth it?
I think the practical implications are very important beyond the duration. So the first dose is the dose when you have the infusion reactions. Probably in 30–40% of patients you see these reactions. And they're like allergic type of reactions. But also importantly...
What kind of reactions are they for those who haven't used it?
Well, you have like drops in blood pressure, tachycardia, you could have breathing.
Often upper respiratory, isn't it?
Upper respiratory, exactly. Patients who have asthma as a background history, they need to be on bronchodilators to prevent that from getting worse. But I think there are important other aspects. You need to make sure you do type and screen if you need to give blood later, because the drug interferes with the workup you do in the blood bank. And also, when you draw the blood for evaluation of the M-spike, because the drug is a monoclonal antibody, it's going to show up as a band in the workup in the lab. So if the patient has an IgG kappa M-spike, you now see that the disease is more prominent because you could see the drug in the laboratory.
Actually, I wondered about that because in the EHA abstract, which is all we've seen so far, the complete response rate was astonishingly high, and I wondered how they measured that then with the circulating antibody.
So I think they have done reflex assays where they have had idiotypic antibodies that bound to the drug so they could migrate the bands, and then they could distinguish drug from disease. But in the standard lab, those are not available. So I think for the publications, the data is probably a little bit cleaner than in reality. So I think to caution that.
And Rafael, you mentioned isatuximab, that it's also an anti-CD30 antibody. It's a little bit behind in the clinical development, but some data was presented on that yesterday here at the ASCO meeting.
There's a number of studies that are looking at isatuximab-based combination, and as you know, at our site, we have had the privilege of being involved in some of those sites with the leadership of Joe Miquel. I think it's very clear. It's a highly active regimen. Isatuximab is a highly active drug, but just like what we're seeing with daratumumab, the rate of responses increases when it's combined with other agents. And we've seen that with Tom Martin presenting some of the data with the Lendex combinations, which really are fantastic. So I would anticipate it's just going to be right behind the heels of daratumumab and will provide another option. And again, all of this is temporary because now we're going to start talking about new formulations, new routes of administration that will hopefully circumvent some of the challenges with infusions.
If I could just comment one quickly. I think you said a very nice question, which I think highlights something a little bit more deeper, is when you said, is it worth it? And when you say, is it worth it, the conversation that we all have with our patients has always been around risks and benefits, right? Here are the risks and here are the benefits and here's the infusion reactions and here's this, right? And then so you talk about the response rates and the PFS and the long-term survival, et cetera. And I think that's still the most important conversation to have with patients. And the reason I say that is because I think there's been a change in that conversation where I may offer you, would you like, as opposed to giving the risks and benefits, I'm giving you a different conversation, which is subtly different, which is, would you like IV or oral therapy? That does not go into the full depth of the oral because potentially the IV may be much more better tolerated or a much more potent combination. But if you phrase the conversation to the patient as, would you like all oral or would you like all IV, you're not really getting into the depth of the conversation about the risks and benefits. And so I think that if you marginalize the rest of that by asking oral or IV, I think you're missing some of that. So I think it's important when you start talking about this to make sure that as we look at these new therapies to really focus on the risks and benefits, response rates, PFS, long-term survival, and not just, would you like oral or IV, and then have a conversation go from there. And that's just an important subtle point, which I think is important for our physicians.
Ben, just before we close on treating relapse disease, any differences in the elderly versus the younger patient here? What approaches?
I have given daratumumab to older people, and they seem to tolerate that very well. I think that's one of the benefits with the monoclonal antibodies, that they seem to be very well tolerable.
What about elotuzumab in this setting? Would you use Dara first, Elo second, Elo first, Dara second? Jane says we should use them all at some point.
Well, I think it comes back to the same question we talked about before. We don't really know the right sequence, if it's better to do them stepwise or you do the more powerful up front. If you do them stepwise, I do think elotuzumab first, and then you could go to Dara. But no one really knows which model is the right.
Maybe we should use them together.
Maybe that. We don't know that. We don't have the data. We don't have head-to-head comparison. But for sure, in clinical practice, I think for patients with an indolent relapse, there is nothing wrong using ELO first and go to DARA later.